panel discussion was very useful and it has made my job easier. Here we come to the extensive stage, selection of second line and beyond. So, the paradox of small cell lung cancer. They respond very beautifully, very chemosensitive, but at the same time it relapses and making the overall survival very dismal for the patients. So most of the patients, although more than 60% will respond to initial chemotherapy and there may be complete clearance of the disease, but still a majority of them will relapse. And at relapse, around 20% will receive the second cycle, around 50% would be able to receive the second line chemo, and only 20% would be eligible for third line. So this is the difference. We have to classify whether the disease is chemosensitive or it is chemorefractory, as was discussed with Dr. Akhil. The chemo-free interval is more than 90 days or 3 months, then it is platinum sensitive. If it is less than 90 days or it recurs within 3 months, then it will be chemorefractory disease. And in chemo-sensitive disease, survival averaged 6 months classically. However, new agents are coming up that we will be discussing subsequently. And in chemorefractory disease, the response rate is 15%, merely 15%, which is improving now. Let's see how. Again, the disease can be divided as sensitive relapse, resistant relapse, or refractory disease. Sensitive relapse and resistant based on 3 months criteria, and refractory disease if there is no initial response at all. So if there is a relapse which is sensitive, then often we'll be treating with the first line chemotherapy doublet or singlet, and as was discussed previously with madam, the patients who are on maintenance immunotherapy, we don't know what to do, whether we should stop immunotherapy or whether we should continue immunotherapy, and whether we should bring on new chemotherapy. This is all under trials. So if we have resistant relapse, then what to do? New agents have come up now, like lorbenectedin, tarlatamab, and classically topotecan, irinotecan, and various other agents have been used in the past. These are the drugs that we are dwelling into the subsequent slides. Same thing as shown in the ESMO. Here, 3 months platinum-free interval, refractory or resistant disease. Similar thing from NCCN guidelines also. Basically, the options remain the same, whether to give the retreatment with the platinum-based regimen or to give these drugs, in which lorbenectedin, topotecan, and tarlatamab are the main drugs, and depends on the chemo-free interval. So if the chemotherapy-free interval is more than 6 months, then this is recommended that you re-challenge the patient with the same platinum-based doublet. And if it is less than 6 months, that is 3 to 6 months, then again this remains an option, re-challenging of the initial chemo regimen. However, if the duration is less than 3 months, then we have to go for some other agents. And various other agents also that I had mentioned in subsequent, in the previous slides are paclitaxel, temozolomide, docetaxel, multi-agent regimen like CAV, gemcitabine, oral etoposide, and also nivolumab or pembrolizumab. This has been mentioned in NCCN guidelines, but it's not FDA recommended anymore. It was previously recommended, but now it has been withdrawn. So these are the timeline of the drugs, how they came into the picture. We have good old cis etoposide that came way back in 1970s and 80s, and thereafter in second line, topotecan was introduced way back in 1998. So almost for 30 years, this was an area that was still. We tried, but there was nothing that would come up. So it was a big blast when lorbenectedin came into the market. And they told it was almost 30 years, nothing was there, and now this is a new drug which has come up in a big way. And in between, in third line, nivolumab and pembrolizumab were also approved, but they were later withdrawn. And not only lorbenectedin, now recently, 2 months back, this new drug tarlatamab has received accelerated approval by US FDA. So this is how at ASCO presentation they showed that the landscape is changing for small cell lung cancer. Now it is in second line terbinectedin and tarlatamab playing a major role. ADC is also coming up into the picture. and platinum re-challenge, topotecan, irinotecan have taken a backseat. While previously, classically, it was platinum re-challenge and these drugs that played the major role, and in 2000, and recently even terbinectedin was approved 2000, as I told you. So terbinectedin, this is a synthetic marine derived alkylating agent and analog of trabectedin, which is derived from sea squirt, and we should be actually thankful to this organism for giving us these two life-saving drugs. Lurbinectedin is an alkaloid with pleiotropic effects, including inhibition of transcription, induction of single-strand, double-strand DNA breaks, and induction of apoptosis. So this was the paper based on which lurbinectedin got the accelerated approval. It was a phase 2 basket trial, including 105 patients and 9 tumor types. Lurbinectedin was given every 21 days. And it should be noted that prophylactic use of GCSF was not permitted, and that is the reason a lot of patients had neutropenia as side effect. These were the baseline characteristics. It is good to note that CNS involvement patients were only 4%, and those with prior immunotherapy, which is now the standard as we discussed previously, was only 8%. Some patients had chemotherapy-free interval of 3 months, that was 40%, and some patients had more than 3 months. Overall response rate was 35%, which is very, very good for a second line drug, and based on this the approval was given. So obviously it was seen that those who had a chemotherapy free interval of more than 90% and less than 90% had different responses. And the common side effects were low grade fatigue and nausea, and grade 3 or 4 neutropenia was seen only in 23% of the patients, and this was because I had mentioned previously, can anybody tell? Yeah, prophylactic GCSF was not given. So they even tried, because lurbinectedin was working so well, why don't we try it in combination? So they came up with this Atlantis study, but unfortunately it failed. So another agent, tarlatamab, this is a BiTE, and it is the first BiTE in any solid tumor. And therefore it directs the patient's T cell to the cancer cells that express DLL3, and this DLL3 is expressed in around 85 to 90% of small cell lung cancers. So this is how it attaches. It brings the cell together, the T cell are drawn into the tumor, and then T cell mediated tumor cell lysis takes place. It's a novel agent, it's a new thing, because classically small cell lung cancer is considered to be immunologically cold tumor. So this was the paper in NEJM, which was published in October 23, and now we had this approval coming up. They had actually compared 2 doses, 10 mg and 100 mg of tarlatamab, and the patients are heavily pre-treated in the form of that the median lines of prior therapy were 2 lines. So we have here an agent working in the 3rd line, and let's see what the response comes up. Even more than 3 lines of prior therapy also, 40 to 30% were like that. So this is the overall response rate, 40% is really astonishing for a patient, for an agent in 3rd line to go such a nice response rate. And median PFS was 4.9 months. As we have seen in previous immunotherapy first line settings, even there the median PFS is around 5 months only. So this is in 2nd or 3rd line, reaching this much PFS is really great. So coming on to the adverse effects, cytokine release syndrome was in 51%, but grade 3 was only in 1%, and mostly events were grade 1 and grade 2, and only 3% had discontinued because of transverse related adverse events. Coming on to the good old drug topotecan for 2nd line. So IV and oral, both forms are available. They have similar efficacy and toxicity, and there were trials that showed greater symptom management in comparative to a multi-agent regimen, that is CAV, by IV, and oral topotecan showed similar increased survival as compared with best supportive care. And it's good to note that topotecan also has good activity against brain metastasis, whereas our lurbinectedin that I showed in the first draft, that had only 8% of the patients were having brain metastasis. So FDA has approved this for patients who are relapsing after more than 45 days, However, the response rate is bad, 20%. And adverse effects, topotecan is not so easily tolerated. Most patients have hematologic side effects, and even other toxicities like fatigue, alopecia make it difficult to tolerate for the patients. Other agents that can be used in the second line are irinotecan, paclitaxel, temozolomide, gemcitabine. Temozolomide is for those patients with brain metastasis, and there's an agent amurubicin which is approved based on a phase 2 trial. It is approved in Japan, not by US FDA. Irinotecan is an alternative to topotecan, and overall response rate ranges from 16 to 47%, and adverse effects as we know classically. So coming on to the immune checkpoint inhibitors. As I told previously, the tumors are immunologically cold, so it's not working here. So although the nivolumab and pembrolizumab, initially they were considered as single agent options for later line, third line and beyond in metastatic small cell, but they are no longer approved by US FDA. Coming on to patients with brain metastasis, response rate in previously treated patients is bad, 22 to 50%. Agents are topotecan, temozolomide, carboplatin, irinotecan, and adding whole brain RT to chemotherapy would increase the response rates. Now this is an agent which is not there anywhere else. It's trilaciclib. It's a CDK4/6 inhibitor that is used to decrease the incidence of chemotherapy-induced myelosuppression in patients with small cell using chemotherapy. And ADCs are coming up in a big way. Even in small cell cancer, various ADCs have been, they are undergoing evaluation. This one which is coming, expected to come is infinatamab deruxtecan, and it has got that TDXD wala same DXD. So the same adverse effects would be expected. Topoisomerase 1 inhibitor, as I mentioned. And these are the other newer trials which have been published, which may come up. Even anti-GD2 antibody, dinotuximab, PARP inhibitors, ATR inhibitor, all these agents are being evaluated. So finally, but this always remains as an option. If the patient has poor performance status, let us not trouble the patient. It's very difficult to be on the other side of the table. So if required, you should always consider palliative care as an option. And so we have here finally the take-home messages. The majority of patients diagnosed in small cell lung cancer will relapse, and on relapse, we have to classify whether it's platinum sensitive or refractory. Platinum sensitive, then we have to re-challenge, which is a better thing. Otherwise, platinum refractory, dulorbenectedin, topotecan, tarlatamab, irinotecan, temozolomide, and upcoming molecules are ADCs, and palliative care also should be kept in the back of our mind. So thanking you, thanking our patients who have made us reach so far. And it's good that past 10 years have made more progress than the previous many decades combined. So we should move forward with optimism and hope for second line small cell lung cancer. Thank you.